Our fourth video will concern developing dynamic eyes for transmural necrosis and not being fooled by some persistent myths about the presence of Q waves. In this video, we will introduce one principle and three rules. They will answer the questions, why do Q waves happen, and what are markers of abnormal Q waves? The Q wave principle is that Q waves can indicate depolarization, normal or abnormal, or transmural necrosis. In depolarization, as seen on the left, electrodes see septal depolarization, and this accounts for the deflections as seen in V5 that we call Q waves. However, as seen on the right, in the setting of transmural necrosis, electrodes see through electrically silent necrotic tissue towards vectors oriented in the opposite direction, further away in the heart. Q wave rule number one is that Q waves are not normal in V2 and V3. You don't see any Q waves in lead V3 here, and that's because V2 and V3 are not in a good position to pick up or see septal depolarization. So Q waves in these leads should raise concern for transmural necrosis. The caveat is that Q waves can become baseline abnormal findings, but in the acute setting, deep Q waves can occur in less than an hour, especially in the anterior distribution. Working myocardium depolarizes, and therefore makes R waves in the leads it faces. Accordingly, we have principle 2. If there's an R wave, there's salvageable myocardium. Let's say it again. If there's an R wave, as seen on the left, in the green, there's salvageable myocardium, and it is worth cathing this patient if they have this tracing and persistent chest pain. This 1995 paper in the Journal of the American College of Cardiology demonstrates how Q waves appear early and do not correlate well with duration of symptoms. In this study, over half of patients seen within the first hour of symptoms had abnormal Q waves on their initial ECG. Additionally, the correlation between duration of symptoms and the number of abnormal Q waves on the initial ECG was poor. This, along with countless individual cases, rejects the proposition that the presence of Q waves indicates the futility of efforts to restore perfusion to territories where Q waves are present. The third Q wave rule regards concerning Q wave proportions. Qs that are over 40 milliseconds wide, a small box, are over 25% the QRS magnitude are concerning for ischemia. In particular, a somewhat wide Q wave is not something typically associated with a chronic structural cause. Having noted the unreliability of Q waves as a marker of ischemic time, with the Q wave associated transmural infarct, you can roughly expect the above timeline with persistent Qs but gradual recovery of T waves over weeks to months. Some patients will not develop T-wave recovery, however, and approximately 60% of patients with completed MI who manifest persistent ST segment abnormality will demonstrate ventricular aneurysm. This, as you can see above in blue, can be difficult to distinguish from late Q waves, as seen above without the blue background. Q waves are among the oldest significant findings in electrocardiography in acute MI. It's been long recognized that MIs associated with Q waves are bad, and it's true, they're worse. But it's important to recognize the limitations of Q waves. First, they don't reliably predict or localize necrotic myocardium. Second, they do not reliably predict the duration of acute MI. Third, they can be associated with various baseline structural abnormalities from hypertrophy to Wolff-Parkinson-White pattern.